Hello. Hi, I'm Dr. Omar Bey, and welcome to OBHealthy, the Doctor's Lounge. We're a group of Black physicians, and we're here for two reasons. Number one is to improve the health of people of African descent. Number two is to encourage young Black males to go into medicine, to be that example, because we surely need more males, Black males, treating our people out there as far as their medical problems are concerned. All righty. Our webinar is every second Saturday at 1 o'clock. And please let you know that you can go into our webinar, obhealthy.com, and click on the doctor's area or click on the YouTube area, and you can see all of our past webinars. And please go in, there's so many topics, and it's important that you just review those topics because it's an education for us as far as medicine and taking care of our bodies. Um, Please subscribe to our YouTube channel so that we can continue to bring this to you. Type, this is important. Type all of your questions in, even if today our topic is heart failure, acute heart failure. And even if your question is not about heart failure, type your question in because we're here to answer your medical questions. All righty. I'd like to thank OB Healthy for allowing us to bring this webinar to you. And without them, we couldn't really do this. So check out their website and see what's going on. Have a lot of health information there. The most important thing I can say today is please do not change any aspect of your medical care until you consult your physician. So important. Only your doctor truly can take care of you from a medical standpoint. Okay. All right, thank you. Now, those of you that have been with us in the past, you understand that our docs, there are several of them that have already emailed me and said that they're in the OR or whatever, but they'll be joining us as the hours go on. Today, we are talking about acute heart failure. And, without the heart, without the ticker, we're not here. This is an important topic, such an important topic. And we have someone that's just an expert in this field to talk to you about it because I always say from A to Z, we're going to talk about heart failure. And that's so important, so important. So right now, I'd just like to allow everybody to introduce themselves. There's only three of us now, but others will be joining. Dr. Atherley, can you introduce yourself, please?
Certainly. Good afternoon, everyone. I'm Trevor Atherley. I'm an interventional cardiologist, predominantly based at Newark Beth Israel Medical Center. And it's a pleasure, as usual, to be here, but it's an even greater pleasure to work on a panel with one of my colleagues, Dr. Matthew Montgomery. Maybe I can tell you a little bit more about him after he introduces himself, but I will say, just very briefly, Dr. Montgomery is one of the young stars of the Division of Cardiology at Newark Beth Israel Medical Center. He is an expert and an academician. He's done a lot of work in the field that he'll be talking to us about. And interestingly enough, he's also very gifted with his hands. He's excellent at interventional or invasive cardiology. So we get together quite often in the cath lab or on the floors discussing patients. So it's a real pleasure to work on a panel with Dr. Matthew Montgomery, who will be our starter there. I'll be just listening.
Well, I'm gonna let Dr. Montgomery tell me about Matt. Give me some past. Give me some past. Where you number one? Where you from, brother? Where'd you go to school? Why are you in medicine? What drove you towards this? Because you're one of the young stars out there that we're just so happy to see. Tell me a little bit about Matthew Montgomery. Who are you, brother?
Sure, no, but first, before I get into about me, I would be remiss if I didn't, acknowledge really the value of this platform and the value of both Dr. Bay and Dr. Trevor Atherley and all of the Black physicians that have worked tirelessly to put this on and whose, shoes that I stand in and try and fill every single day going forward with caring for patients and really having impacts on the community because it's so important. And it's because of people like you that I have really wanted to charter out a career in medicine and continue to try and provide interventions in the community as well as in academic medicine and in the field of cardiology. So, I thank you all for that very, first. About me, I grew up in Michigan, just outside of Detroit, Michigan. I grew up there, and then I went to college at Xavier University, Louisiana, down
Mhm.
in HBCU down in Xavier. And at the time, and even now, we are. And the reason that I went there was because I wanted to become a physician.
Okay.
And at the time, they were number one at putting African Americans in medical school, and I believe still number one or within the top three. And so
Mhm.
after that, I attended medical school in Philadelphia, Philadelphia College of Osteopathic Medicine, and did my residency and fellowship training throughout Philadelphia and New Jersey.
Mhm.
And so I've been at Newark Beth Israel practicing both interventional cardiology, but mainly advanced heart failure and transplant cardiology for going on almost 5 years now. Be 5 years in November after I completed my fellowship training there. And it's been a great experience to be able to work, at the Beth and to be able to provide, state-of-the-art therapy in the field of cardiovascular and heart failure and interventional cardiology in a in the community where we provide care to our community. So it's been a great experience.
Excellent, excellent. It's just so important that our young brothers out there hear how we made it, or how we got through, or where we went, or you know what I mean, because it just stimulates that possibility in their brain that, hey, yeah, I can do this too, and that excites me. That excites me. That's for sure. So I just want to get into to the the meat of it all as far as heart failure is concerned. But first, I want to start just by you explain the heart. How does the heart work? And the blood going through it and going through the lungs and coming back into the heart and all of that kind of stuff. It can be confusing to someone who doesn't do it every day. Can you just step back and explain the basics for us?
Sure, definitely. And this is a question that I get oftentimes a lot from in the office from patients that are very inquisitive about how the heart works. You hear so much about it all the time. And so, a lot of, times these concepts, understood or can be somewhat confusing, but it is something that's very important. And so if you think about the heart, the way that I break down the heart whenever I think about it is in essentially three different sections. One of them is structure or muscle or sort of tissue. The other one is the electrical aspect of the heart, and the other one is sort of the arteries or blood vessels of the heart. So I think of it as a house, so to speak. Every house has a structure. Along within that structure, you need electricity in order to power the heart. You also need plumbing essentially to be able to get blood flow in so that you can provide support to the heart muscle and everything else. And so that's sort of how I think about the heart. Looking specifically at each individual area, blood flow through the heart is and just through the cardiovascular system is similar to, our highways and roads, on, throughout states and towns where you have arteries which pump blood flow from the heart to all of our other major organs, from the brain all the way down to our feet. And then you have veins, which return blood flow from all of our other organs back to the heart so that the heart can then provide blood flow back and it's a continuous loop. And so when we talk about the structure of the heart, we divide it mainly, the easiest way to think about it is both a right and a left side. And so the right side of the heart is essentially where everything starts. When you have blood flow through our veins, that is essentially drained all the blood and all the nutrient after blood flow has circulated through all of our organs, the liver, the kidneys, etc. And our organs have extracted all the nutrients, the oxygen, and everything else that it needs. It flows back to the right side of the heart. It flows back to the upper side of the right side of the heart, ultimately to the bottom side of the right side of the heart, and then that pumps blood to the lungs. And this is very important because at this time, once blood flows through the lungs, as we breathe in oxygen and breathe in and out every single day, the blood then picks up oxygen from the lungs and goes to the left side of the heart, which ultimately gets pumped back out to the rest of the body, and the whole cycle repeats itself again. And this is happening thousands of times a day, every single day, and overnight for us to be able to, function regularly and do our activities of daily living. And so that's how I think about the structure of the heart. And so so that's essentially the house and the overview of the main house. When you talk about the intricate components of other aspects of that house, you have to look at the electrical activity of the heart. The heart can't beat without its own electrical activity. It's one of, if not the only organ in the body that has its own intrinsic sort of mind to continue pumping, even if it's outside of the body and not being controlled or being influenced at all by the brain activity. One of the most interesting things to see is if you see a heart outside of the body or anything during, particular times I've seen with heart transplants that I've been involved in, the heart will beat outside of the body for a decent amount of time. And because it has that intrinsic pacemaker in order to regulate the electrical activity of the heart. And it beats in a very coordinated fashion so that the blood flow will flow regularly from the right side to the left side of the heart and then ultimately out into the bloodstream and then repeat that process again. And so this electrical activity, again, is happening thousands of times, tens of thousands of times every single day.
Mhm.
And then finally, when we talk about the piping of that house, which is sort of the heart arteries or the coronary arteries, and this is, out of all of cardiovascular disease, these are one of the most talked about and most, I would say, probably conceptual wise understood aspects of heart disease, because we talk about coronary artery disease, which is essentially disease of the coronary arteries where you develop increased cholesterol or increased, fatty deposits within these coronary arteries, which over time can develop complete obstruction of the blood flow, which is to provide blood flow to that heart muscle. This, what I'm describing, would be an acute heart attack, in which case you would present with, sometimes classic, but not even always, classic symptoms, which I'm sure we'll talk about going forward, but such as chest pain or shortness of breath or etc.
Mhm.
All of these symptoms can arise from dysfunction or blockage within the heart arteries. And you can have dysfunction in those arteries, whether that's 100% blockage or 50% blockage, which
Mhm.
ultimately can lead to heart disease. So
Right.
each one of these areas, either the function of the heart, the electrical activity of the heart, or the coronary arteries, all can have some form of disease within them. And unfortunately, over time, disease in one of these or combination of all the above can lead to heart failure.
Yeah. The thing of it is that, and you said, I just want to back up, um, uh, coronary arteries. Um, these are arteries that special arteries that actually are that feed the heart itself. Explain coronary arteries. I know it's a big word, and the public may not understand what coronary arteries are. I know we have basic arteries that go throughout the body, but explain what a coronary artery is.
Sure. So coronary arteries essentially are arteries, but they sit on top of the heart muscle. They are
Mhm.
attached to the heart muscle. And instead of providing blood flow to any other organ in the body, they provide blood flow to the heart muscle, because
Mm.
the heart muscle needs blood flow and oxygen and nutrients, just like every other organ in our body does as well. And so these arteries provide blood flow specifically to that heart muscle so that that muscle can provide pump enough to provide blood flow to the rest of the body.
Excellent, excellent. You said something else too that really that keyed me in is that you can take the heart out of the body, and because it has its own little pacemaker ticking off electrical signals, it still pumps. I always thought with being a pulmonologist that the lungs were the most. The heart works for the lungs.
Yes.
But I guess the lungs work for the heart if it's pumping all the time, huh? All right,
Yes.
great, great, excellent, excellent. Um, what are some of the causes? Let's just step back for a second. Heart failure. All right. I know we've been throwing this word around, these two words around. What is heart failure?
Okay. So heart failure I'd like to think of heart failure as a syndrome. And the reason I say that is because it does start with the heart muscle. And ultimately, the heart muscle does two very important things. oftentimes think about heart failure or weakness of the heart muscle as being the heart's inability to squeeze. And so
Mhm.
we have, the heart squeezes with every beat and it squeezes the blood flow out to provide blood flow to the rest of our body. But as we as we know and have found out that the heart failure can be caused by the heart's inability to squeeze correctly or the
Mhm.
heart's inability to be able to relax correctly.
Mm.
And relaxation of the heart muscle is just as important as the heart muscles being able to squeeze, because if the heart muscle can't relax as well, you're not able to get blood actually into that main pumping chamber of the heart in order to be able to provide blood flow to the rest of the body. Likewise, if the heart muscle is weak with squeezing, then it will not be able to adequately be able to provide that blood flow and squeezing mechanism out to the rest of the body as well. And
Mhm.
so it's important to kind of, within the heart, that's why I call it a syndrome, because it can include both of those dysfunctions within the heart muscle.
Mhm.
And so, you know, it it really is defined by symptoms, and it's largely a clinical diagnosis, where with shortness of breath being one of the large predominant symptoms of heart failure. You also can have symptoms of swelling in the legs or swelling in the abdomen with retaining a lot of fluid, and really just overall feeling very sluggish, feeling fatigued, and really not being able to, perform and do a lot of the activities that you were able to do over the course of maybe, let's say, a couple of years ago or even 6 months ago. And so
Mhm.
when I talk to patients all the time and I want to try and define sort of whether or not they have heart failure or not, despite their the exact functionality of their heart, a lot of it is based on symptom assessment and how overall they're actually feeling.
Mhm. Mhm. Yeah.
Matt, I certainly appreciate your discussion. I want to put a little bit more if we can. Most patients, when they come to me and they're told, well, you have heart failure, the heart has failed, they automatically think of a weak heart. How often do we see a situation where the heart is really not weak? It's squeezing well, contracting well, but the other aspect of heart function is what puts them into heart failure. Do we see this much?
Yes, and so that's when we talk about that. And actually, it's about 50-50 now, or a little
Good.
bit 60-40, where you
Mhm.
have heart failure due to a weak heart, or you have heart failure due to a, heart function that has inability to be able to relax well.
Mhm.
And
Mhm.
so, right, normally it's about 50 to 60% due to a weak heart, and about 40% due to the heart's inability to relax. And both of these dysfunctions within the heart muscle can lead to symptoms which can be synonymous with the heart failure syndrome.
Right, right. You know that it's good, and you've explained that well. The thing of it is that I'm trying to understand what the heart muscle would be like if it's weak. Does it mean that it's all shriveled up and small, or does it mean that it's too big to function, or it's grown too big and then the muscle doesn't work anymore? And as far as the ones that having squeezing difficulties, is it because, it's just too stiff now to squeeze, and why would it be so stiff? Is it scarred, or what's going on with those two aspects? I think you introduced it well, but tell me what's wrong with it that it won't pump.
Right. So, you can get, when you do have, heart failure and it's due to the heart function being weak and not squeezing, that what that means is that over time the heart actually does dilate and become larger. And when it
Mm.
becomes larger, that contributes to its inability to be able to function well. And as you know, what we say a lot of time, well, what I say and what a lot of my colleagues say a lot of times in heart failure is that, unfortunately, with cardiovascular disease, most, if not all, roads do lead to heart failure. Whether or not you have dysfunction within the actual muscle, whether or not you have dysfunction in the electrical system or dysfunction in the coronary arteries, that either untreated or persistently progressive over the years can and will lead to heart failure. And
Mhm.
so that leads into what can cause it. And so that's when we always talk about, risk factor modification, or looking and paying attention to other other disease states that are common, such as high blood pressure or high cholesterol or diabetes. One of the things that is very common that we, unfortunately don't have any control over is family history or genetic abnormalities. I always tell my patients that, you can't outrun or can't outwork in the gym your genes. And so you have to really pay attention to those and really understand if these are aspects that you carry, to know about them. Knowledge is power. Know about them and really work um, get regular checkups, see your physician regularly, get regular screenings, etc.
Mhm. Right, right. Usually in your office, when somebody presents, how do they usually present? Somebody's coming into the office and, of course, their wife drug him in, you know what I mean? And he
Yeah.
feels like there's nothing wrong with me. Why is she drink? Why is she complaining? Da, da. How do they usually present? Is it usually like, um, a situation where they just had a little tickle pain and they came in, or is it that, I've been short of breath for the last, year and I haven't been able to walk upstairs, but now it's gotten worse? How do they usually present to your office?
So to back up just a little bit, I think going into how they really present, and that is interesting, and it's unfortunate because a lot of patients that I see for the very first time, um,
Hmm.
I see in the hospital, and they
Oh.
present initially, they'll present because they say, Doc, I just couldn't take it anymore. My legs were swelling over the last number of days or weeks,
Hmm.
and I just had to come and figure out what was going on. Or, I was so short of breath, not just with moving around or working at my job, which, let's say I'm a truck driver or I'm on my feet all day with my job. And, what I was able to do a month ago, now I'm, huffing and puffing trying to walk up the stairs because I can't really do it anymore. And I just
Hmm.
had to come to the emergency room or to the hospital in order to find out, to get some answers. And so
Hmm.
that, unfortunately, it's a lot of times an acute presentation of the heart failure that we see. And then we backtrack from there. And as we do more of a history, we find out that these symptoms may have been more long-standing than we would have noticed previously.
Hmm.
Um, and that is something that I think, like you said, with us, we a lot of times don't want to, with it, don't want to go to the doctors, or we don't, if we're not feeling any symptoms, or we think that maybe we just slept wrong, so we're a little bit tired today. These are all things that can be contribute to, or can be signs and symptoms that you're having an underlying issue that potentially um, could be treated appropriately. And then the other way that patients do present is exactly like you said, where they, saw their primary care physician, and, maybe they, got screenings and got an ultrasound of their heart, which showed that their heart function was weak. And then they were
Hmm.
referred to either a cardiologist, or if the general cardiologist, or if the symptoms were severe enough, to ultimately come to a heart failure cardiologist, where more, workup and more additional testing would be done.
Right. And in talking about testing, and you're just so great. I got all these questions, man. In talking about testing, you just said something, an ultrasound. When they come to your office, what are the basic tests that you're going to do immediately for these patients to get a true assessment? I know when I did my training, I remember the professors talking about, history is 90% of
Mhm.
diagnosing, you know what I mean? Get a good history. And that is 110%. I believe in that. Um, but what tests do you do when a patient comes in to assess their hearts appropriately?
So the very first test that I do all the time is an EKG. When they're
Mhm.
getting in, if it's a new patient, you have to get an EKG just to give a baseline assessment of what's going on. You can tell a lot from an EKG, whether or not their heart rate is regular, or whether or not it's irregular, which could be a sign that there's some underlying disease with that electrical system that I spoke about, whether or not the heart rate is fast, if the heart rate is slow. These are a lot of baseline characteristics that, without even really going through the complete history, I can have an idea when first talking with the patient, to understand sort of what exactly will be going on. The
Mhm.
other thing that I like to do is, after doing some assessment with symptoms, we can do a test, which is called a 6-minute walk test, which is essentially a test where, I have my medical assistants in the office can, go out and walk them around the office for about 6 minutes, and we chart their oxygen level in their blood with a pulse oximeter, and
Mhm.
we, track their blood pressure and their heart rate while they're walking. And this test has been shown over decades to have had a lot of prognostic implications about, sort of, cardiovascular disease, and even, the current state or even the progression of possible heart failure. So these are the two initial tests, besides physical exam and, other regular things that we would do, that I can do in the office during that first visit to get an additional idea of what's going on. And then after that, the um, next test I oftentimes order, if they don't have a recent one, would be an ultrasound of the heart or an echocardiogram. And then from what I find from there will dictate what will be, ordered later.
Mhm. Mhm.
Okay.
Yeah,
Great.
excellent. Go ahead, Dr.
Well,
Cord.
I was going to ask the doctor, what are the different types of heart failure that you usually see?
Yeah, so a lot of times we'll see it. The main two buckets would be heart failure that is due to blockages in the arteries, or heart failure that is due to what I call a whole other mixed bag of things. And so blockages in the heart arteries would be um, oftentimes can be a reversible cause. If you come into the hospital for, let's say a heart attack, and you're found to have an artery that is, blocked 100%, you can get treated for that, immediately, and you can have the artery opened up by one of the interventional cardiologists, and then, that has restored blood flow to the heart muscle. And unfortunately, this can a lot of times and oftentimes result in heart failure or a weak heart muscle. But that is a reversible cause that hopefully over time will get better. No, now the other mixed bag of things is oftentimes can what I call the mixed bag of things can be due to a whole other aspect of things, which is either other systemic illnesses such as high blood pressure or high cholesterol. It can be due to genetic abnormalities. It can be due to other illnesses such as amyloidosis, or other aspects of systemic illnesses that ultimately the heart can be affected by. And so these, you know oftentimes I find that the mixed bag, or the medical term for it, is the non-ischemic cardiomyopathy, or the heart disease that's caused by, you know some of or singular other medical type condition, can a lot of times be, you know more difficult to treat, because it can include a lot of other collaboration with a lot of other specialists. You have to undergo a lot of other additional diagnostic mechanisms, and it can be more of a detective sort of um, endeavor to kind of figure out what the underlying cause is, and then once you're able to determine that, if it is something treatable, then initiating treatment, and then hopefully over time you will have some improvement in that heart function, or if not necessarily that, improvement in the patient in their functional status, which is just as important.
Just wanted to add one little aspect, of course, um, and that is valve disease. Well, we mentioned some degree of elaborate nature. You mentioned the flow of the blood from the right side to the left side, etc. But we want to emphasize to some patients and to the listening audience that things within the heart, like the valves, play an important role in directing the flow, so the blood is able to flow properly and smoothly from one chamber to another, and not to leak backwards into the chamber that it came from, or not to have a stiffened valve which prevents the blood from going easily. And that these diseases of valves may also lead to the congestive heart failure. Perhaps you don't see as much of it as we used to in the old days, when rheumatic heart disease, rheumatic fever, was a thing that was much more rampant. But nonetheless, it is still an important cause of heart failure, even nowadays.
Yes, agreed. Very
Dr.
much so.
Montgomery, I frequently send my patients to the cardiologist, and they send me back a report saying this patient has systolic heart failure or diastolic. Can you elaborate on those two types?
Sure.
What is
Yeah.
called
So
systolic or what's called diastolic heart failure? And what are the
Okay.
usual causes, so we can educate our patients?
Sure. So systolic heart failure is synonymous with what I mentioned earlier with the heart's inability to be able to pump. And so when you talk about a heart function, the heart's function has two essential functions: its ability to be able to squeeze and its ability to be able to relax. The ability to be able to squeeze, the medical term for that is systole or systolic, and the heart and the ability to be able to relax, or the relaxation phase of the heart, is called diastole. And so the inability of the heart to be able to relax is considered diastolic heart function, and a diastolic heart failure rather, and the inability of the heart to be able to squeeze would be considered systolic heart failure. Now all of this is largely based on the chamber of the heart, because the heart has four chambers, as we mentioned earlier: two chambers on the right, on the top, and two chambers on the bottom. And you have a right and left chamber on the heart, a right and left chamber in the heart, top part of the heart, and a right and left chamber on the bottom part of the heart. And the main um, parameter that we pay attention to evaluate heart failure is for the left ventricle, or the bottom left portion of the heart muscle. And so when we speak about systolic or diastolic heart failure, and the heart's either inability to be able to squeeze correctly or inability to be able to relax correctly, it is specifically speaking to that left ventricle, or that main pumping chamber of the heart, which is largely responsible for providing that support for blood flow to the rest of the body.
Very good. What tests would you do to differentiate between these two?
So you would do an oh, Dr. Bay, I think you're muted.
You are so right. I'm talking, and thank you very much. I usually say that to others.
Right.
The thing of it is that systolic and diastolic. I always think of it as um, that chamber, bottom left chamber, that actually has the most power to squeeze blood and send blood into the arteries. And those arteries, that main aortic artery, delivers blood to the rest of the body. But that sets up, Dr. Court, with our blood pressure as well. And talking about the systolic and the diastolic as far as blood pressure is concerned as well. That contracting, pushing blood out, and relaxing of that chamber, and letting that blood vessel, the pressure in that blood pressure coming down, then that would be the diastolic. And that's what you're talking about as far as that chamber actually being able to relax and take in blood so that it can push out appropriate blood for that pressure to build up in those arteries for the next blood, the next systolic, which is part of our blood pressure. Um, Dr. Court, what I wanted to ask you, and hold your question, because I wanted to ask you a question.
Okay, mention that.
When you see patients in the office and you're referring them to a cardiologist, what keys that for you? What keys that for you to say, this, I got to send for an appropriate evaluation on this patient because I think it's the heart, but it could be something else. I need a specialist to tell me what's going on and why it's happening. How do patients present to your office that you would think about sending to a cardiologist?
In reference to heart failure, the most common presenting symptom that I see in the patient is shortness of breath
Mhm.
and bilateral leg edema,
Right, right.
just
Mhm.
for heart failure alone.
That's for heart failure. Well, that keys me into a question that came up, and this is we're gonna. And please, those in the audience, please don't be shy to type in your questions. We're here to answer your medical questions. I'm going to keep emphasizing that because it's so important that everyone out there get their questions answered. It says, if you have swollen legs after a long flight, is it due to heart issues or something else? And I know that's kind of a broad question, but Dr. Montgomery, can you start off with that one? Just give us some idea of what see if we can give an answer for this particular question.
Sure. And this is a very important question because, just that scenario of, swollen legs after a long flight is can be something that it can be extremely, extremely concerning, or it can be something that could be benign. And so if we can unpack this for a little bit. So if you have, whenever you're in a let's say sitting down for a longer period of time, and you're not up walking or doing anything else, blood can pool down in your legs and you can get some, edema or swelling, which oftentimes we'll call sort of dependent swelling, or swelling that is in the legs that is there simply because of maybe how you're sitting or that you're resting and you're not up walking, etc. And this type of swelling, oftentimes, we've all had it when we're on our feet all day or we're sitting in the chair all day and we get home, we put our legs up, and then that swelling improves. Um, that is, in this case scenario, that would be the best case scenario for that. It can also be due to in that case, it wouldn't necessarily be due to heart failure. It would be due to possibly just, you having a little bit of extra swelling, or just your inability of not walking for a prolonged period of time can just develop swelling in the legs. Now, on the specifically talking about heart failure in this scenario, this can be a sign of heart failure, and it is something that if it continues over a long period of time, not just, this one period, it would be something that I would recommend to, go to your physician and really get an additional evaluation for, because it can be a sign of heart failure in and of itself. Now, a lot of times you'll see that in conjunction with other symptoms such as shortness of breath or fatigue or etc. But it can be a sign of that. And then very lastly, and I'm sure, Dr. Bay is a pulmonologist, you can speak more about this as well, but it can, after a long flight, one of the main things that we get concerned about is whether or not, especially swelling in the legs, whether or not you could have a blood clot. And that would be something that would be specifically in this question, that would be something else that would be concerning.
Yeah, definitely. Just as far as the blood clot is concerned, and let me expand on that just a minute. As far as our legs are concerned, when you're in a long flight, and I just had a long flight, and unfortunately or fortunately, I'm above 6 foot tall, and your knees are against the seat there. Your legs are bent at the knees, and the blood flow return in the veins is it can slow down a little bit and get a little sluggish. Understand that our blood flow returns back to our heart, especially in the legs, through muscle activity. And if we're not, put it this way, it's supported by muscle activity. That's not the only reason, but and there are valves there that allow it to kind of ladder the blood back up towards the heart. Well, if we're not walking around, then that blood pools in the lower legs, and the fluid part of the blood is easily diffused into the tissues, and we get swelling. Um, the one thing that from a pulmonary or a pulmonologist or a lung specialist point of view, I get concerned about is if that blood flow slows to a point where it develops clots in those veins, and some of the major large veins in the legs, and a piece of that clot can flick off and travel up the venous system or up the vein system up into the heart, and then through the right side of the heart into the lung, and get wedged in one of the lung vessels, and the patient gets extremely short of breath, and that's called a pulmonary embolus. And that means the blood is not flowing through the lungs to get oxygen, so that the patient gets short of breath. And that's what I get concerned about also. If someone says that their legs are swollen after a long flight, it may not, as Dr. Montgomery stated, it may be nothing, but it could be something that would be very concerning, that must be checked out right away. Anybody else have any other anything to expand on that? Because I feel from a pulmonary standpoint, it's an important aspect of what we do, is to, and pulmonary embolus or is one of those type of problems that if a physician thinks, even if it comes into his mind that this could be, oh, I don't think it is, but it possibly could be, you should be evaluated for it. It's one of those type of problems that if we miss, it could be devastating. So even if I think of it, then I rule it out. I'm going to ask
I
you to
think
do
that's it.
certain tests.
Very important point, Omar, because missing that diagnosis can be fatal. I think that it's important for the patient to note not just that there is swelling, but whether it's one side or both sides.
Yes.
Usually, the clot will form more predominantly on one side rather than the other, and therefore that's a big clue to us. When that happens and the patient seeks medical advice, then the onus is on the doctor to aggressively pursue a diagnosis to see exactly what it is. Because again, we nowadays have the tools to go in and intervene. Much as we can go in an acute heart attack, we can go in and intervene and help get rid of the clot that's blocking the artery to the lungs, pulmonary artery. So it's important. Time is of the essence. Important for the patient to seek medical advice, either from their own physician, who may then speedily send the patient to the emergency room. But then you trigger off a whole series of responses from the team to look and determine whether or not a clot, a dangerous clot, is forming acutely in the veins of the leg.
True, true. Very, very well put, Dr. Atherley. Dr. Court, you have your hand up there.
Because in this patient, in this particular patient, that what he's asking about is most probably like more venous insufficiency, since it's on both legs. Because
Right.
clots usually don't occur in both.
Yes, true, 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 true.
So,
That's not the usual presentation. It's true. And venous insufficiency, doc, is I know that's a word that we throw around all the time, but what are you talking about? You're talking about the blood's not coming back.
coming back into the system because the veins, the valves don't work. Just like you tried to explain before. That's the most common reason why you get that.
Right, right, right. And that's another thing. If you have a history of this, meaning that if you sit down at work and your feet swell a little bit, and then when you go home at night and you have a good night's sleep and wake up in the morning and all the swelling is gone, a lot of times that can either be mild, or I would say, and I'm not a cardiologist here, mild heart failure or just basic venous insufficiency where the valves have gotten old and they don't push the blood and the blood is not being pushed along appropriately in the venous system. All righty. Let's talk about then, Dr. Atherley, you brought this up just a second ago. Let's talk about heart attacks. All righty. What's a heart attack? I mean, we throw that word around a lot. Well, you had a heart attack. What's a heart attack? Either Dr. Atherley or Dr. Montgomery, either one that want to jump in there on this one.
I will let our guests initiate the discussion, but I'll be willing to add little things, bits and pieces if I see fit. So Matt, you want to take us through?
Oh, so a heart attack is essentially a blockage to either close to 100% or 100% blockage of those arteries that run across the top part of the heart or the coronary arteries. And so these, when you have a blockage like that, you oftentimes will present or have symptoms of classically chest pain or shortness of breath, even fatigue, or it can be nausea or even vomiting. You can have a lot of various types of symptoms, but one of the main hallmark symptoms is shortness of breath. And the key is that it's really acute onset. And so it's really, blockage within any of these heart arteries. And it's very important that if you do have any of these type of symptoms or this type of chest pain that is new or something that's acute or you haven't had it before, it just seems off, that you seek medical attention urgently, because that is considered a medical emergency. And it's something that over the course of the last, number of years, 10, 20, 30 years, we've developed a very good system in this country in order to be able to care for patients like this. And the outcomes have definitely improved for treating that.
All righty. Excellent. Excellent. Go ahead, Doc.
One may understand the underlying predisposition to total blockage of the arteries, however, because the arteries may be partially blocked, as I think Matt had alluded to before, by fatty deposits, often associated with cholesterol, high cholesterol, deposits in the walls of these arteries. The artery is like a tube. And once it is open adequately and not blocked, the blood can flow properly through that tube. Partial blockages may limit the degree of blood that flows through the tubes to the rest of the heart muscle. And that may give some warning signs of pains, etc., but not quite a heart attack. But when a heart attack occurs, it's a dramatic and acute presentation where that artery becomes blocked. Oftentimes, there's a rupture of the covering within that artery, the lining or the covering of the atherosclerotic plaque. I'm throwing terms out because you hear them and see them in the news nowadays. Atherosclerosis is the process of the fatty deposits in the artery, and there's a little covering, and sometimes that ruptures, allowing spillage of materials into the inside or the lumen of that tube, and that can then trigger off or precipitate a full clot forming. When that clot forms acutely, then it suddenly shuts off the blood supply. So you can imagine that a part of the heart muscle, which was previously fed with blood, even if at a lesser degree, suddenly becomes totally deprived of blood. And the muscle immediately tells us there are signs and symptoms that we're able to recognize, and there are some symptoms that the patient may feel, and these have been well described. But the onus is then on us as the physicians, having made the diagnosis, to do certain tests to make the diagnosis rather quickly. And then if you make the diagnosis, to get in there and dissolve away or remove that clot. And I should tell you that Matt is one of the experts. We have teams of physicians, of cardiologists who are on the standby, so that if a patient develops a clot and is brought to the emergency room, within moments, we have teams available so that within a few minutes, they can carry the patient to the cardiac catheterization laboratory, diagnose or recognize that there's a clot there totally blocking the artery, and then do the appropriate measures to remove it or dissolve it as necessary. So that may be life-saving, and even if it is not immediately life-saving in terms of life or death, it certainly can prevent or diminish the amount of damage that occurs to the muscle. Because unfortunately, if you have a heart attack, the heart attack leaves permanent scarring on the muscle. However, we know that the heart attack develops slowly. When I say slowly, it's not an instantaneous, sudden hit, but it develops, the damage that occurs to the muscle develops over minutes to hours. And so it is possible, even if a certain portion of the heart muscle is damaged with a pure heart attack, that by removing that insult to the heart, removing that clot, that we can limit the total amount of, or size of the heart muscle, which becomes permanently damaged. So time is of the essence. It is therefore important that when patients feel symptoms, as I think were being partially described, feel symptoms or has a suspicion, that they come to the emergency room as quickly as possible. And those of us who've been on the so-called STEMI teams, like Matt is currently, we all have lots and lots of experiences and stories to tell of patients who were almost dead, but have come and we're able to help them in a timely manner. I always remember to deviate, I can tell you a story with a patient who was scheduled to take a plane across the Atlantic to Europe.
Go ahead.
He was sitting in the airport, waiting anxiously and annoyed that his flight was delayed. He went to eat something at one of the cafeterias and suddenly had this severe chest pain. About an hour after his flight was supposed to have departed, quickly he was diagnosed as having a major problem, sent to the cath lab, and we were able to bring him into the lab and see that the major artery in the heart was blocked. One of the major arteries, you will know, Matt, is the left anterior descending. One of the major arteries was blocked. We were able to remove the clot and restore him to good function. But all that struck us was, suppose he'd gotten on the plane and was halfway across, well, a good way across the Atlantic on his way to Europe. What would have happened? And we know what would have happened. So time is of the essence.
Yes. You know, Dr. Atherley, two problems, medical problems that bring that to mind. Number one is, and I think it's changed as far as the lives saved, is number one, cardiac teams are available at hospitals that can respond in minutes, and stroke teams. Those two teams that most hospitals, well, I shouldn't say most hospitals, but at least Beth Israel, I know Beth Israel has, it saves so many lives because we can get to the patient quickly, and we can prevent, we can prevent damage in the brain and prevent damage in the heart if we can get to the patient quickly before that damage occurs. Oh, excellent. We have a couple questions actually, and let's go ahead and tackle some of these real quick. And Dr. Anderson, I see your title comes up. I don't know if you're having a problem coming in. If you are, then please give me a text. If not, then we look forward to seeing you come joining the panel. First question. My friend had a lung transplant and a bypass on Tuesday at Temple University in Philadelphia. When when he goes home, what is the average time of recovery? Dr. Montgomery, can you give us some enlightenment?
Sure. So, lung transplant is a bit different than heart transplant, but it still is part, thoracic organ transplant. And so, when we talk about recovery from that, one of the most common things we're speaking about is sort of recovery from thoracic surgery, which is essentially surgery when you're going down traditional surgery, you're going down and actually taking a knife and cutting open the sternum or the breastbone so that you can open up the sternum and then in this case do a lung transplant. And I believe you said had a bypass. I'm assuming that's a cardiac bypass.
Yeah.
Yeah,
Mhm.
so both of those surgeries are done, it can be done at the same time, and then you would go back and put sutures or put sternal wires to close the sternum. And so on average, the sternum, normally will heal within 6 to 8 weeks. Now, it doesn't mean that you won't have any residual pain or anything from that, but we oftentimes, at least, we recommend that our patients don't drive specifically, for about 4 to 6 weeks so that we can be rest assured that the sternum is healed. So in the case of there being any type of God forbid an accident or anything else, they're not injured by say the airbags, they're not injured by hitting the steering wheel or any of these other issues. So you will start to see a decent amount of improvement, 4 to 6 weeks, and then after that, from just the surgical aspect of it, the improvement, as far as pain or residual discomfort will gradually get better. And hopefully by 3 or 6 months shouldn't really feel much at all.
Mhm.
Healing from the actual lung transplant and dealing with other aspects of it is a little bit different and variable from person to person.
Yeah, I agree. From a lung transplant and dealing with lung transplants for many years, it really depends on the person, um, um, the nutritional, um, um, uh, how nutritionally stable they are prior to the transplant, um, and I think to a certain degree, healing, um, to me, healing, 50% of healing is your mental state. And those patients that are willing to make that effort several days after the surgery or even a day after the surgery, we get those patients out of bed, they start moving. Um, if the tubes that were put there in the chest to drain the fluids post surgery come out within a day or 2 or 3 days, move it along. The patient's moving, starting to eat. They were nutritionally, stable prior to surgery. They were a good surgical candidate. They move along quickly. And I would say within a week or so, the most of the tubes are out. They're walking around the wards. They're off the ventilator. They're breathing on their own. They may need just a little oxygen support, but they're moving along, appropriately in an appropriate way that we feel that patients are healing in post surgery. Um, each patient is different, as Dr. Montgomery said. So you can't, not knowing the patient, it's hard to say, but this is sort of the average that that I look at from a pulmonary standpoint. Dr. Atherley, you have your hand up?
Yes, I wanted to benefit the audience from some of Matthew's expertise, as we know he's a transplant cardiologist. Maybe you can tell us a little bit more about who deserves a transplant. People don't just come and say, well, I'd like a heart transplant, that is.
Mhm.
What are the circumstances under which we feel is important to recommend that a patient should consider having a heart transplant? When is that?
Sure. So when we talk about heart failure, both when we mention both systolic and diastolic heart failure, the heart's inability to squeeze correctly or difficulty with the heart being inability to be able to relax correctly, there are stages of that. And so really, when we start to talk about the need for a heart transplant, it means that you're at sort of the end stage or the end of the line, if you will, as far as heart failure. And way that looks is, you have very, very severe symptoms, not just swelling in the legs, but also you can have symptoms, of of swelling in the abdomen. You can have symptoms of fatigue, tiredness, and really just overall not feeling well. And also, what we see is we can see a lot of lab abnormalities with this as well, because the heart is so diseased and so weak that it's not able to really contribute to performing a lot of the blood flow that direct giving the body and other organs a lot of the adequate blood flow that it needs. And so at that point, once we have determined that, and once, if we get a referral for patients, that we do a comprehensive evaluation, a comprehensive workup to see, you know, well, first we decide whether or not we think they should be considered for a transplant, or whether or not, clinically speaking, they need to be evaluated. And this would be inclusive of a lot of different tests and a lot of different, both invasive and non-invasive testing that we talked about, such as an echo or sometimes even a heart catheterization, to kind of look at all of the lab values and everything else to say, okay, this person definitely has, end stage heart failure and is in need for a transplant evaluation. And then once that's determined, then we go through the whole process as a team, which is inclusive of a lot. Our team here at Beth Israel is, inclusive of coordinators and social workers and other physicians and everyone else, where we go through the process completely, and we, from soup to nuts, from A to Z, and we really discuss it with the patient, really want to make sure that everybody's on the same page. And then from that standpoint, we decide whether or not a transplant will be in order.
Mhm.
And
Yeah.
this is very important too, because there's a lot in addition to really looking at the medical aspect of this, there's a lot of social interactions that we have to really consider when we're talking about dealing with the transplant. Because, one of the things that we always want to make sure of is that it's a very involved notion. And so a transplant, in by sheer nature, is specifically stating that, someone else, there has to be a donor that is going to donate the organ for the patient, in order to be able to live and have a second chance at life. And that's something that, we as transplant physicians, and really just want to make sure that we don't, that's not an endeavor we take lightly. And we want to make sure that we are able to, allocate, and participate in allocation of all of these hearts and organs in individuals that we know would definitely benefit from them, and that we know overall would be set up to have in the best possible shape to be able to succeed after they get the transplant, which is why the evaluation prior to undergoing transplant is so extensive. And
Mhm.
oftentimes, if I've been told by patients, can be rather exhausting, but it is for a reason.
Yeah, I know, and I know that lung is probably very similar to cardiac as far as some of the things we look at. So a psychological exam, because as you stated, Dr. Montgomery, you're given that second chance at life. So a psychological exam, nutritionally, are you fit enough to survive and do well pre transplant and post transplant? To understand that you have family support, things like are you able to take your medicine, and will you be compliant with the medication? Because understand what you're actually doing when what's happening, I should say, when you actually get a transplant, be it lung or heart. You're taking a foreign object or a foreign organ, I should say, not an object, a foreign organ, and putting it into a person's body. Now, our bodies are excellent at fighting foreign things that enter it. And our bodies are going to try to reject that because it's not supposed to be there. It's somebody else's, and the body is saying, where is my heart? Where'd this come from? And the body's going to say, I'm going to attack it because it doesn't belong here. Well, there are certain medications that are given for lung as well as heart so that the body doesn't attack that organ, so that that organ is able to function and do what it needs to do. So there are many aspects of that are very important in making that decision as to whether this patient is appropriate for a heart, and because it's a big deal, and there are many aspects that has to be checked off prior to the approval. And I don't know, Dr. Montgomery is very familiar with that, dealing with that every day, but just wanted to say that it's just, you know, it's a life-saving procedure, and you want to make sure you give that life-saving procedure to someone who really is going to appreciate it and do everything everything they can to preserve it. Mhm. Anything else?
I was going to ask along the same lines. We sometimes send patients to Dr. Montgomery to assess and analyze their suitability for heart transplants. But what are the red flags, Matt, that determine for you, and maybe should be told to us, what are the reasons for outright refusing to do transplants on these patients? How bad the heart is, or how bad the rest of the body is? What are the sort of things that you look at? You say, no, this is not a suitable candidate. Sorry. And maybe then offering some of the alternatives that you might do, you know, LVAD or something else that you might offer as a partial path rather than a transplant. So can you tell us a little bit about them? Who don't need it?
Sure. Yeah, you know, there's clinical and non-clinical factors that can be, you know, of the point where we say this is either a red flag or something that we would say is that we cannot proceed, you know, because of this particular situation. So clinically, one of the major things that we pay attention to is your BMI, or your body mass index. This is dealing with, you know, if, you know, BMI greater than 40 is considered to be morbidly obese. And whenever you have, and studies have shown that whenever, you know, anyone with a BMI over number of 40, those results tend to be worse. And so part of the initial evaluation would be, okay, what is their BMI? And this is what's called a modifiable risk factor, because your BMI today may not be your BMI in 3 months. And so when you're able to hopefully, you know, get a referral early, these are things that we can potentially work on. Some of the other red flags are uncontrolled other systemic diseases. So uncontrolled diabetes, uncontrolled high blood pressure, um, you know, either, you know, social history such as, you know, active smoking or active drug use. These are all factors that would be not just red flags, but would be things that we wouldn't be able to pass at this particular time, because, you know, we would want to not only ensure that the patient is going to be in the best possible shape to succeed after they undergo transplant, but also, you know, we have to be good stewards of, you know, the organs, and making sure that the recipient of that definitely is going to, you know, care for that organ properly and really live a healthier lifestyle so that they can get the best chance, their second chance of life as well. So those are a lot of the clinical factors. Non-clinical factors are things like Dr. Bay mentioned, such as family support, social support, you know, compliance with medications. These are all things that are important, and these are all things that, you know, from variability from team to team, that we have to really discuss and really kind of talk to the patient and to other clinicians that know them well, to get a better sense of not just their compliance, but also you know, other aspects of their social support and things like that, which is why it's so important that we have our social workers and other aspects, other members of our team that really are able to delve into these other non-clinical factors and give all of us in our meetings a better overall picture of how the patient is outside of the examination room. And so it's very much so a team sport when we look to doing transplant evaluations. And those are just some of the immediate things that we go into, and obviously you can get more granular with some of the other aspects of it. And then ultimately, I think you mentioned it, Dr. Atherley, that let's say there's somebody that, based upon either clinical or non-clinical factors, may not be a candidate for heart transplant. Um, there are other therapies, specifically an LVAD, or mechanical heart pump, or left ventricular assist device, which over the course of the last, you know, 5 to 10 years, the advancement of technology has been exponential and been staggering, to where this is an actual pump that sits inside of that main pumping chamber of the heart, the left ventricle, the bottom left chamber of the heart that we spoke about earlier. That pump sits in that ventricle, and it actually bypasses blood from that chamber of the heart and diverts blood out to the aorta, which is that main artery of the heart. And this is implanted via a traditional open heart surgery. So it's still considered major surgery, but it is a what we call a durable device or a machine, if you will. And so it's something that can be implanted any day of the week. It's not in what we think of as a limited resource. So it's not something you have to wait for a donor for or anything else. And the requirements or the workup in order to be able to qualify for this type of device are often less stringent than it would be to um, medically and non-medically be able to be considered a suitable transplant candidate. And so there has definitely been an increase in the implantation and utilization of these devices, not just at our centers, but throughout the country. And it's definitely becoming a very good, viable, if not in some cases, only option for certain patients for not just a prolongation of life, but being able to kind of have a better quality of life as well.
Now, let
Not,
me ask you.
oh,
Go ahead, Dr.
I was going
Anthony.
to ask a question based on something you said, and maybe the audience may need an explanation. You mentioned the BMI as being one of the factors that is used. So I know that Dr. Bay is an expert on the nutrition and perhaps can tell us how to achieve a good BMI, but just roughly so our audience may know, it's a matter of relating the patient's weight to their height.
Right.
And it does not take into consideration the totality of what makes up the weight, whether it's a muscle mass, as in some of the average football players, for example, or whether it's just fat or bone. But nonetheless, we define certain norms where roughly 25 is normal, between 18 and 25 is underweight, 25 to 30 may be overweight, and more than 30 is what we call obese.
Mhm.
You may see people who qualify to be called obese who may not appear that way to you.
Mm.
But we use that to help define the patient's risk in some surgical procedures, and that has been mentioned by Dr. Montgomery. Omar, how much of a role does a BMI play in your assessment of patients from the nutritional viewpoint?
Oh, it's dramatic, and it's high on the list, Dr. Core. I mean, excuse me, Dr. Atherley.
We often get mistaken, don't worry.
Don't even
That's
try
true.
it.
That's
It's
Don't
true.
true,
even
James.
try.
That's true.
Um, the BMI. I mean, weight is a factor that and understand uh, that affects every aspect of the body, and no matter and the way I think about it is that our heart has to pump and our lungs have to supply and our liver and our organ, every organ has to supply a certain blood or nutrients or do its function in relation to that weight. Now, for our height and our weight, there's a certain, I mean, for our height, there's a certain weight that we should carry. And this was back in the 40s or 50s. The Westinghouse had put a chart together for your height, how much weight you should, what would be your appropriate weight. Unfortunately, and just like most things, um, people of African descent, we were not a part of that study. And if you find, and there are so many differences in races, what race you are. And you'd be surprised from a medical standpoint how many differences there are. For instance, a lot of Caucasians have no problems with salt, and we're going to deal with that. The next question is about salt, so that popped it. But salt is something that we cannot handle, and why? It's because we were from Africa and we were in warm weather through ages and ages. So salt, we had to retain our fluid. If you're from a cold weather climate, you don't have to worry about becoming dehydrated because you're in a cold weather. So salt may be over the ages, salt may affect your body differently. The thing about let me just get back to weight. As far as the BMI is concerned, um, where I was going with the height is and your weight is that there is certain amount of weight for height, and if your heart has to work to pump, just to use that as an example, for a BMI of 40 when it should be pumping for a BMI of 25, over time it's going to give out. It's not going to be able to do what it needs to do for the time period that it should. So these patients usually, expire early. They have decreased functionality. For instance, they come into the office and they say, well, I don't have a problem walking. Okay, do you walk upstairs? Well, no, I don't walk upstairs. I take the elevator. Well, you understand what I'm saying. You gravitate to who you are and what your abilities are. In your mind, you feel you're okay. So yes, BMI is one of the major indicators that I use if a patient, especially when you're talking about transplant, whether they're going to do well or not. And I know that was a long way around that answer, but I just wanted to be clear on that. Um, yes, yes, number one for me. Patrick, hi. I'm glad you could make it. Let's do this. Let's do this, Patrick. It's time for halftime, and I know we're running over a little bit here. Let's reintroduce everybody. Let me do my halftime thing. We have quite a few. We have like 6 or 7 questions here that we have to answer. And Dr. Montgomery, you're just wonderful. I'm so glad that you're here today. Let's do this. What I'd like to do is first thing is just reintroduce everybody. Patrick, can you start us off? Introduce who you are, and just in case. Uh,
Eh,
Go ahead.
Hi everyone. I hope you can hear me. I was having some
We
some
can.
technical difficulties, but I'm Patrick Anderson. I'm a gynecologic oncologist. I work at Newark Beth Israel, where I practice with these illustrious gentlemen we see on the panel. I see a few of us are missing today, but it's always fun and an honor to be here the second Saturday of every month.
All right. Thank you, Patrick. Dr. Court, can you introduce yourself, please?
Good afternoon. My name is Dr. James Court. I practice in East Orange, New Jersey. My specialty is internal medicine.
Okay, Dr. Atherley, please.
I'm Trevor Atherley. I'm an interventional cardiologist. I practice primarily out of Newark Beth Israel Medical Center in Essex County.
All right. And Dr. Montgomery.
I'm Dr. Matthew Montgomery. I'm a cardiologist. I specialize in heart failure cardiology as well as interventional cardiology. I work at Newark Beth Israel and spent some time at Jersey City Medical Center as well.
All righty. And as usual, the first time we introduced ourselves, I forgot to introduce myself. I'm Dr. Omar Bey, pulmonary critical care and a subspecialty in nutrition. And just so happy to be here with all the brothers. All righty. Understand that we are here every second Saturday at 1 o'clock. And all you have to do is just go to OBHealthy and hit that doctors tab and sign in and just come in and ask your medical question. And we're going to get to these questions in a minute for the second half. If you want to see our past webinars, just go to the website and hit the YouTube channel. All of our past webinars are there, and just educate yourself as far as health is concerned and get a Black perspective on these diagnoses and different medical problems. The most important thing I can say is please do not change any aspect of your medical care until you consult your physician. Only your doctor, and I truly mean that, only your doctor can truly take care of you from a medical standpoint. And I'd like to thank OBHealthy for allowing us to bring this webinar to you. Without them, we just couldn't do it. So check out their website and see what's going on health-wise. All right. This is what I'd like to do. I'd like to answer some of these questions. And I did get distracted a little bit on that last question because I read this question before. Let me go with this. If I decide to strictly restrict salt intake, how long would it take to conclude it affects my elevated blood pressure? And Dr. Court, that's one thing that I know you see blood pressures all the time, and we all do. But as far as salt is concerned, and I had alluded to this earlier, that salt is one of the things that African Americans or people of African descent, we have a problem with salt. I mean, it's one of the things. There was this large study done throughout several countries for about 5 or 6 years. I came across this study some years ago, and it looked at what elements of our diet most affect our bodies. And is it salt? Is it sugar? Is it fats? Is it and it came down that salt was the number one thing that affected us from a medical standpoint. So, Dr. Court, what do you tell your patients, and how do you handle that as far as salt is concerned, and when their blood pressure should turn around? Is there a time period that you expect them to come back and say, yeah, the decrease in your salt really helped, or have you had that?
I think blood pressure is multifactorial. It's related to genetics and the type of foods that we eat. And but the role that salt plays, I think it increases the blood volume. These
Mhm.
patients will tend to respond very well to more to diuretics rather than the calcium channel blockers. Again, compliance is most important because, of course, many patients don't comply unless they have pain.
Mhm.
They don't think they're sick, but the most important aspect is you have to have the blood pressure checked
Right. Mhm.
and follow the directions of your doctor. I don't think anyone can predict how long it's going to take. It's an
Right.
individual thing. It's
Right.
not that way.
I agree on that. It's definitely an individual thing. Dr. Anderson, your hand is up.
This question is more for Dr. Montgomery and Dr. Atherley combined, because when we talk about salt, I think we're alluding to sodium chloride. But in terms of the broad definition of salts, there are several salts that influence the volume that we retain, um, that's required to retain our volume equilibrium, and it's influenced by your kidneys. So it's not just sodium, it's potassium, it's magnesium. And I think that's why when folks who have renal failure, we look at the magnesium level, we're worried about the potassium level, because all of these does influence muscle function. And I think with potassium, primarily the heart, right? So for the cardiology guys, I often joke and say, help me when it comes to the heart. I don't fix hearts, I break them. And I break them in many ways, both surgically and with some of the treatments that I offer patients, chemotherapy and otherwise. So, in terms of salt, can we break it down to specific agents, sodium, potassium, magnesium, and how does that influence the heart and the blood pressure?
Mhm.
Yeah, so I can start. So when we talk about, and that's a good point. So when we talk about salts, as far from a heart failure perspective, one of the most important things is sodium chloride, because what we typically do say is that, water or fluid tends to follow salt. And so, you can have a patient that has systolic heart failure or heart failure due to the weak heart. And if they, and if they have, a salt, increase of a salty meal or salty foods or anything else, they can definitely have a lot of fluid retention, which ultimately can cause them to have, a heart failure episode. The running sort of commentary is that, a lot of times after major holidays, whether or not it's Thanksgiving or Christmas, and you have, a lot of fellowships surrounded by food and really good food, that oftentimes you'll have patients will present to the emergency room after, a couple of days or a few days of some dietary indiscretions or such. And so a lot of that is due to sodium. And then, when we talk about, magnesium and potassium, these are other, salts or minerals that definitely do affect sort of the heart function. And, obviously a high potassium can, have large detriment to the heart's ability to be able to function electrically and really affect your heart rate to the point where it can cause you to have arrhythmias or irregular heartbeats. Um, and so all of these things do work in tandem. And as you have sort of fluid shifts and things like that from increased absorption of water due to sodium chloride, or and the way it's filtered through the kidneys, it can cause a lot of abnormalities, which can lead to a lot of these issues of dysfunction.
Just to mention that as the question was phrased, there was a question about hypertension. And a lot of the concerns that were raised for heart failure, as mentioned by Dr. Montgomery, also would relate to high blood pressure, especially the systolic, or the first part of the high blood pressure,
Mhm.
affected by salt, especially sodium chloride.
Yes.
If I can expand on the question to add another element to the discussion, and I'm asking this because honestly, I don't know. So salt are dissolvables. And if I should follow you, Dr. Montgomery, wherever we have more dissolvable, there goes more fluid, right? Can you talk about another dissolvable, which is glucose in the blood, and how that affects blood volume and ultimately influence heart failure?
Sure. Yeah. So, if you have, which is why all of these things sort of work together. So you talk about high blood or increased salt intake or high blood pressure, which can be due to increased salt intake for sure, because as you think about it, the fluid or the volume is going to go um, from a high concentration to a low concentration. It's going to want to go to dissolve certain areas where the salts or the solutes are a lot higher in concentration, and so the fluid is going to go to try and do that. And that can be with salt. It can also be with glucose. That's another one that will cause that. But the difference, or one of the different things with glucose, is oftentimes if you do have long-standing, let's say, diabetes, or you present in an acute diabetic episode, you oftentimes will be or can be dehydrated because you're constantly urinating to try and get rid of that additional glucose that's in the blood and that's being filtered up through the kidneys. And so you can become dehydrated with that, which ultimately can cause the blood glucose to either stay the same or go a little bit higher. So these are, like you said, solutes and all these other factors that do have a lot of uh, effect on blood volume. In my experience, what I see, at least mostly from a heart failure standpoint, is more of a sodium chloride and having them either secondary due to uncontrolled blood pressure or dietary indiscretions or not eating the appropriate foods, which causes this progressive or steady state of increased blood volume or fluid volume in a constant setting.
Excellent, excellent. Let's go with some of our questions. We have some dynamite questions here. The next one is it time for a heart test? It states, my cholesterol is 220. My mom had a pacemaker. My brother was diagnosed with a heart attack. My father transitioned at 57, question mark, question mark. My PCP visit um, for a physical is 7/2, question mark, question mark. So it seems that he's given us a little bit of a history here. What do you think as far as is it time for a cardiac evaluation? Dr. Montgomery, you start that off?
Just from what I'm hearing here, it sounds like, I would say you have multiple risk factors for heart disease. And heart disease, whether or not that's coronary artery disease or heart failure or some strata in there. And it sounds like, there's elevated cholesterol or high cholesterol, family history, given that, you had I believe you said your father had a transition that in his 50s from a
57.
57
Mhm.
from a heart attack. So whenever we consider what's called early heart disease or coronary artery disease, it normally is considered to be in the 50s, in the low 50s, where you have some type of coronary event, whether or not it's in the a heart attack or heart failure. And so, this sounds like it's will have some genetic abnormalities as well as other risk factors with high cholesterol and questionably high blood pressure. So I would say yes, it probably is, time to consider getting additional testing and really evaluation from your primary care physician. And there's multiple new testing routes that you can get in order to decide if you do have any underlying coronary artery disease, such as you can get a cardiac CT with calcium scoring, which is similar to a regular CT scan, but it's a lower dose CT scan, and you can evaluate if you have any calcifications in those coronary arteries, which we spoke about, which can provide a large amount of um, of understanding up front without a really real invasive test to see if there is any increased risk of you having heart disease. And so that's, something to start out with, as well as other lab tests and looking at that, possibly even an echocardiogram and an EKG, like we said, which we check earlier. So I think it's probably time to consider a comprehensive evaluation.
But can I ask though, from you mentioned the CT, the cardiac CT,
Yes.
that's more of a diagnostic test, right? So is there a screening test that one could add to your list of wellness panel that we should look at, similar to a colonoscopy or even CT screening for lung cancer?
Yeah, so I mean, you could additionally would be ordering more of a panel of blood work, inclusive of sounds like the cholesterol was ordered, but there are other, obviously you want to check, the blood count and the kidney function to make sure there's not any other systemic sort of difficulties with blood tests or abnormalities there. And then also really not, and there is a based just upon your history. And I'm sure, and I know Dr. Atherley, we've talked about this before, and we've had some issue before where you can really, it's all about risk stratification and risk prognostication, and it's largely based on history and what the patient has. So you can actually go with they have risk calculators out there where you can actually plug in your entire sort of medical history, family history, etc., and it will actually give you a risk calculation of what your risk is of developing cardiovascular disease in the next 10, 20, or even 30 years. And so that is a good place to start. Specifically pertaining to this particular question with this patient, I am concerned, given the age and the other factors that were listed, that an upfront sort of moderately aggressive strategy for trying to evaluate what may or may not be there for them now, I think would be very appropriate.
I think the question here is an assessment of the patient's totality of risk for cardiovascular disease. And you can go through one by one several different characteristics. I'd have to ask the patient a lot more specifics, however, but there are one or two that he's mentioned. For example, the cholesterol of 220. We know that is an elevated cholesterol. It's important, however, nowadays to look at the breakdown components of the cholesterol. There's a good cholesterol called the HDL and a bad cholesterol called the LDL. And primarily, if we oversimplify the role of these, the good cholesterol essentially removes bad cholesterol from the bloodstream and helps to be excreted or broken down through the liver. Whereas the bad cholesterol is deposited in organ tissues. And the one we'd be most concerned about would be depositing bad cholesterol to help harden the arteries of the coronaries. So that's an important one. We should therefore look at the breakdown of the cholesterol and determine how much is good and how much is bad, knowing the normal levels. Nowadays, we're a little bit more stringent on what should be the level of bad cholesterol that's tolerable or acceptable. While 100 was at one time considered, then 70. Now in patients who have very high risk or who have had previous documentation of coronary artery disease, we've dropped that level all the way down to 55 for the LDL or the bad cholesterol as the desirable ones. Then we look at the other factors, family history. Dr. Matthew Montgomery already mentioned the role of family history in a few specific circumstances. Certainly, I think he mentioned his mother. Was it the mother? No, the father and brother had heart attacks at young age. The father had a sudden death, which may have in fact then been secondary to coronary artery disease. One may make that assumption, but the brother has documented coronary artery disease. These are clearly risk factors at a younger age. The mother has a pacemaker. Now, again, a pacemaker is merely a device to help improve the heart rate if the heart rate should become slow for whatever underlying reason there is. And that is only sometimes related to coronary artery disease. But there are many other circumstances with the need for pacemakers. Is it a simple pacemaker or is it a pacemaker with a defibrillator? There are a few of these factors that we would have to ascertain better. So I'd say, first and foremost, for me, actually, would be to get a full history, get more details from the patient as to some of those factors that exist. If we see a significant number, 3 or more risk factors, then we'd be aggressive in terms of our approach. Again, nowadays, we very commonly go on to calcium in the coronary arteries, as mentioned by Dr. Montgomery. But if necessary, especially if there are symptoms, if he had symptoms of either overt chest pain or symptoms that may have suggested an equivalent of the chest pain of suggesting blockage of the arteries to the heart, then one might do things like a simple electrocardiogram first, then a possible stress test. There's some specific kinds of stress tests which one might do depending upon the degree of risk, and several other so-called non-invasive tests before going to the level of an invasive one, which would be putting tubes into the body to better define the anatomy of the coronary arteries. And that would only be done if there's a high degree of suspicion that they're blocked. So there are many things that could be done, but I would say first and foremost, I'd want to have a better history on him and get some more details of some of the things that he's identified.
Yes, definitely. Definitely. All righty. Excellent, Dr. Atherley. We have quite a few questions, so I want to make sure we get through these questions because that's what it's all about. I'm 74. It states I'm 74. My mother is 98, healthier than her child. Now, if this is, you know, just one of the things that I love to hear, that we have a parent that is 98 years old and healthy. That means the likelihood that 74-year-old is going to become 98 as well. And it's just you just got those beautiful genes that's just carrying you on, and be thankful to God that you have them. Oh, good to hear and glad to know it. Next one. It just says that that was referring, I think, to the blood pressure question, and it states that the patient was on lisinopril for high blood pressure. I think that was one with, as far as salt is concerned. All right, good to know that you're on that blood pressure medication. This one states that I joined late, but if you haven't already discussed this, please talk about the connection between poor dental health and heart disease, which is important. And boy, I don't think of it often, but even for transplant and all of that, and lung transplant, guess what we do? We send them to the dentist prior to. Can we talk about that a little bit?
Yeah, so dental health and oral health is very, very important. It's I believe, it's underestimated as far as this level of importance, but specifically in cardiology, we find that oral health has a direct correlation to cardiovascular health in a lot of ways. One of the specific ways can be oftentimes poor oral health can lead to infections, bad infections, abscesses, things like that, which can, cause blood positive or bacteria in the bloodstream, which can take up residence in the heart and cause, a heart condition known as endocarditis, which can, lead to, which is when the bacteria takes up residence either in the heart muscle or on one of the heart valves. And this can cause the heart valves to become very dysfunctional, ultimately resulting in either the need for a new heart valve or a valve replacement, or, more severe treatments or surgeries from there. So it's very important from that standpoint to make sure that you have, excuse me, that you obtain, oral health from there. And then just my anecdotal thing, I think that, the mouth and having proper oral health, you want to decrease sort of level of inflammation that you have there. And that can sometimes lead to overall, increase inflammation throughout the entire body, which can, lead to poor cardiovascular health because you're having a constant sort of increase in your excitability level, or et cetera. But it's very, very difficult to, or it's a very large correlation between the two.
Excellent.
Well, it is difficult to set up proper randomized control studies that we like to use as the epitome of scientific study. There's no doubt, however, that observational studies have shown, and there's a conglomerate of 18 of these put together, looked at the relationship between gum disease and heart disease. And there's clearly a relationship in several different ways. We're not sure exactly the mechanism, but one was alluded to by Dr. Montgomery, that is the bacteria that may go into the bloodstream from dental abscesses, dental caries, etc. More likely to go into the bloodstream when we do dental work, even heavy brushing of the teeth. But importantly, there is clearly a relationship, and the tie-in to the relationship between heart disease and gum disease is perhaps inflammation involving the gums and the teeth, and subsequently inflammatory disease involving the heart, coronary arteries, as well as valves.
Excellent, excellent. Yeah, because I know endocarditis, as far as the ICU is concerned, it's one of the diseases that we're very concerned about. Even treating it is can be difficult sometimes because the valve itself gets infected, the heart valve itself gets infected, and getting that bacteria off that heart valve may be difficult with long-term antibiotics. And sometimes, as Dr. Montgomery stated, it actually needs surgery to rectify this problem. So having good oral care is so important, very important. The next question, how important is eating to your blood type and or ethnicity? Dr. Patrick Anderson. You're the man as far as eating is concerned and you know eating things that are nutritionally just solid for the body. Um,
You know, my
ethnicity and blood type, I'm not sure about blood type, but ethnicity definitely. I'm one that truly believe that you don't have to change your cultural foods to be healthy. It's about portions. It's about within all of our cultures, we have available to us, hopefully, most of our cultures, I should say, available healthy foods. It's about the portions that we put forth that makes our bodies healthy or non-healthy. Patrick, you want to expand on that?
Yeah, and I think, there are the basics, right? Your fats, your starch, your protein, um, and and the notations that come with each component, right? So when we talk about the starches, it's really sugars, and they're simple and complex, and how genetics influence, um, say, sugar metabolism and fat metabolism. That's a long conversation, and that certainly would influence the importance of the component of each element on your plate. So, for example, Dr. Montgomery could consume a higher starch component, and his glucose is less influenced than, say, mine, who may have a family history of diabetes, right? Because genetically we may metabolize the breakdown into for glucose of starches into simple and complex sugars and how we store them, and that may impact diabetes and my expression of diabetes throughout my lifetime. So that's a little bit of more of a complex argument. I think what's important to me, and I think it's so important primarily because of the types of patients I take care of, the cancer patients, is when you have other factors that influence how you metabolize the nutrients that you consume. There are treatments that influence the breakdown, the speed of breakdown, and most importantly, the absorption, right? Because some of the stuff we offer patients does adversely affects, say, the lining of the gut. So absorption becomes a problem. Some of this will cause inflammation, and influence absorption. So I often say to patients, nutrient dense food, and that also includes the micronutrients, the coenzyme Q10s, and the vitamins and the various vitamins. And they pay attention to what foods have certain vitamins in it that are anti-inflammatory, that are anti-cancer, to put it broadly,
Mhm.
and try to consume those, but in a concentrated fashion. And when you have to combine that with oral health, your ability, because just remember, digestion starts in the mouth, right? So when your oral health is not good, the chemical process of breaking down nutrients is influenced significantly. And when you talk about how poor oral health influence the function of your stomach, um, that also influence nutrition. So it's a broad topic. And I often say to patients, what's recommended is 5 servings of fruits and vegetable. And the theory behind that is fruits colored, vegetable colored, right? High fiber level, right? So, and I think fiber is important in how much glucose, how much starch you consume, because
Mhm.
fiber fills you up. You feel less hungry. So you tend to not consume the quote unquote heavy starch meals to take away that hunger. So yeah, the 5 courses of fruits and vegetable, and it's these colored fruits and vegetable that has these important micronutrients in them.
Yeah. I think also, when you want to, as far as being full is concerned, protein is metabolized slower than some of the starches. And once you eat an appropriate amount of protein, understand that if you're eating protein, whatever meats or and try to stay with lean meats, it should be the size of your palm. As far as large, how large it should be, and how much you can, like the major meal of your of the day, what you consume. Also, Patrick, I agree with you as far as colors are concerned. I'm a big one for salads. To have a large salad with your supper or your major meal of the day. To have a large salad, and if you're trying to lose weight or anything like that, then definitely a low cal salad dressing and only 2 tablespoons full. So you think about lettuce, you think about things like kale and spinach. These things they have it's like 90 to 93% water and nutrients, and healthy nutrients for you. So I think that's very healthy prior to eating your major meal of the day. And then when you eat that major meal, try to balance out your carbohydrates and eat more of the salads that not salads, but the vegetables that are on your plate as opposed to the carbs, and keep your meats under control, meaning that try not to eat as much fried food, broil, bake. And these are healthy meals, especially when you're talking about cardiac is concerned. You want to have a diet that supports the heart and not affect the heart in negative ways. So just to give you some indication, if you have, Dr. Montgomery, as far as heart healthy eating, is there any other tips that you would say? Because I think that's so important when we talk about BMI, when we talk about what you're eating, when you talk about a healthy body, being able to handle the transplant if you're getting a heart transplant, or the healthy heart. It's all about you are what you eat. Let's just put it plainly. Do you have any other tips that you get from a nutritional standpoint for the cardiac patient?
Sure. So, really just echo a lot what was already said, really to eat a lot of, like you said, salads, green leafy vegetables, really making sure to have balanced meals. And really what I like to tell patients too is portion control. I think portion control is extremely important to be able to not not overeat, but to eat appropriate portions as far as your body size, and really limit the amount of sodium intake. Should really be, typically less than, 2,000 milligrams a day if you can, and then also keeping down towards uh, uh, staying away from a lot of other things like saturated fats and things of that nature. So you want to try and eat as healthy as you can. A lot of these things are in things that we like you said, fried foods, or even a lot of meats, and a diet very, very heavy in a lot of your animal products or meats or red meats or things like that, are things that definitely can contribute to increase in cholesterol, increase in high blood pressure, given the amount of sodium and things like that that's there. So really, what I always hallmark is say you want to eat balanced meals, you want to eat, a lot of vegetables and green leafy vegetables, and really have appropriate portion control. When you talk about a transplant diet, it's a little bit different because there are a number of things you have to watch out for from an immune system standpoint, such as certain fruits that you may not be able, because they have to be washed properly, and other things to decrease the risk of you getting an infection that you might be more prone to obtaining. So some minor nuances there, but for the most part, cardiovascular health and cardiovascular diets are more equitable, is what was said.
Excellent. Patrick, you have your hand up?
Yes, I just want to ask Dr. Atherley and Dr. Montgomery. A lot of us, some of our lifestyle issues include consuming supplements. Can you talk about some of the heart healthy supplements, whether they're anti-inflammatory supplements, vitamins, and so on, that would promote cardiovascular health?
Yeah, I know, like the fish oils and things like that. Definitely, that you always hear that they help as far as the arteries are concerned, and help to prevent them clogging up and stuff like that. From a nutritional standpoint, the uh, um, uh, goodness gracious, I'm blocking, but the oils, some of the oils that they talk about,
Omega-3 fatty acids.
Yeah.
yeah, well, that too. But one of the diets, the Mediterranean diet, and that's one of the diets they say is more heart healthy than other diets and things like that. Um, and
There's a lot
then
of olive oil in it as well.
yeah, that's what I was trying to think
Yeah.
about, olive oil. I don't know why I all of a sudden blocked on olive oil. That, but the things like that. But as far as healthy diets and supplements, there are things out there, Patrick. I don't know if do you deal with that at all, Dr. Montgomery? Sometimes, I know a lot of my patients actually go to um, 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 more of people like Kevin, who is a naturalist as
Mhm.
far as medicine, and talk with him as opposed to a Western doctor. But do you deal with it much, Dr. Montgomery?
I don't deal with it a lot in my practice. A lot of times I will have I have patients that will, come to me as for heart failure care. And then in the midst of us going through, their medications and everything else, there oftentimes are a lot of questions about, certain supplements that they might be taking, such as, in addition to, your regular multivitamin, but also different components that may be in a multivitamin, such as, zinc or selenium or magnesium and these other types of individual supplements that's there. And the question that I always, in some other natural supplements as well, um, such as like tea root and things like that are there. So there, the question typically is, can I take these, or are these going to interfere with sort of the medicines that I'm already taking, or the medicines that you're prescribing, or do you recommend that I take these? My answer to that is always, I want to get an additional history as far as exactly what it is that you're taking, and kind of obtain more history from that standpoint. But then also want to, if this, in some cases there are, clear, um, clearly studied sort of adverse reactions between um, some of the medications that we will prescribe, as well as some of the supplements that are taken.
Mhm.
And so, some of the supplements can affect if you're on Coumadin, or a blood thinner such as warfarin. Some of the supplements you take can either cause that level to go higher or level to go lower. So I always try and screen for those types of interactions. But outside of that, if there is no other real thing that I know about, I encourage, them to kind of, take whatever has them feel comfortable in that standpoint. But I always do, for our transplant patients, refer them to our nutritionist who does, within our group, who does probably offer a more comprehensive evaluation from that standpoint.
Right. I know
I,
from in the ICU, when I treat patients that may need supplements, and especially patients that need healing, either
Mhm.
post-surgical healing or from decubiti or skin breakdown healing. We give multivitamins, we give thiamine, I give zinc, and vitamin C for that healing process. But those are pretty much traditional vitamins and supplements right there. When you start getting outside of the traditional stuff, I like to always refer to someone who's does natural medicine and as what they do, as opposed to me recommending. Dr. Atherley, you were going to say
I
something,
was going
please.
to say, yes, above all, do no harm. And I think that if I can determine that whatever the patient has been taking or wants to take is not going to be harmful based upon their medical condition as well as upon the medication that they're taking, then I can allow them. But I do not usually recommend that they take those as ancillary unless I have some clear-cut evidence to the benefit of them. And the evidence has been somewhat sparse in a lot of these additional or supplementary things that have been given to diets. I mean, there have been quite a few. I know that Matt might not want to propagate alcohol, but certainly be all aware of the alcohol studies that were first mentioned from France, which did show some benefit. But as we look a little bit closely, it perhaps is not just red wine, it may be other forms of alcohol as well. But to be a little bit more serious, I think that we want to be sure that we don't harm the patients, but I feel a little reluctant to recommend these supplements unless I can find clear evidence of their benefit.
Excellent, excellent. Let's get some more. We have some more questions that have come up. How do you clean out the calcium in your arteries? So I'm thinking they're talking about coronary artery disease and calcium being built up or the fat deposits. How do we clean those out? That's their question.
So the process is really starts with what we just talked about, healthy diet and really medications. And so as it's building up, unfortunately, the main target of treating it is to help prevent its progression. And so if, let's say, you have some degree diagnosed with some degree of coronary artery disease or this calcium that's in the heart arteries via a CAT scan or even some or even a stress test or something along those lines, you want to be on appropriate medical therapy with a statin and with controlling your blood pressure and everything else to prevent further progression of this type of blockage. And then, unfortunately, if it does progress and you do get to the point where you do have a heart attack or a blockage in the artery that causes you to have a heart attack, then treatment of that is acute, which we spoke about earlier, and treatment of that would be cleaning it out with either a balloon, where you would do a balloon angioplasty, which would be where you you inflate a balloon inside of the coronary artery, which does help to dissolve some of that calcium or that plaque that's there. Then also you would put a stent that's there, which is a small metal scaffolding that kind of holds the artery open, and it actually has medicine on the inside of the stent, which helps to hopefully prevent there from being future formation of blockages that's there.
Excellent, excellent. We got quite a few questions coming up, so I'm going to keep the questions coming. How about that? Had a heart attack? No, had a heart lock. Oh, okay. Had a heart lock cleared with catheterization in September. The symptoms have returned, but nothing else was found on 2 follow-up visits. Should I be concerned?
Well, just take that one, I suppose. I'd like to know the progress of what happened. Was the blockage removal successful in diminishing the symptoms that she had? In other words, after that, the pain go away, and has it been a clear interval and then the pain restarted to suggest that something has indeed happened, or was there a problem with the attempt at clearing them? If they were fully cleared and similar symptoms have recurred, similar to those that were there present before the clearing of the blockages, then it highly implies that the blockage or other blockages in other arteries in the heart, that blockages are occurring. Now, 2 visits was mentioned, and it depends on what was done on those 2 visits post-procedure. If the 2 visits were merely examination and simple EKGs in the office, they may not have been sufficient. If, however, this patient presented with the recurrence of symptoms, we have 2 choices: either to go for so-called non-invasive studies, that is, to do stress testing as one of the key ones that it would do in addition to a regular electrocardiogram, or if the symptoms are convincing enough in a patient who we know had definite documented blockage of arteries before, and the symptoms are now severe again, there's a consideration of going back for another heart catheterization. That is the process of passing a tube into the body, into the arteries of the heart, and taking pictures directly of the coronary arteries in a position such that if blockages have recurred and are significant, we define and quantify the severity of blockages, and if they reach a certain level of narrowing of the arteries, then there and then they could be fixed again with stents or balloon angioplasty. And what those mean is that a little balloon can be placed, blow the balloon up in the location of the blockage and diminish or squeeze or compress the blockage, allowing better blood flow through that artery. And stents, the term stent implies putting a small mesh, like a mesh, I suppose, a small device which can be placed or implanted through the same modality into the coronary artery in the region of the blockage, and can squash blockage, but it better prevents recurrence of the blockage in that artery. So those are the invasive, if you will, procedures that can be done if we feel strongly about recurrence of blockages.
Excellent, excellent. We got some good questions here. There was one that one of the dentists, and I'm not going to read but he thanked us for covering what we covered as far as cardiovascular disease and oral hygiene, because it's important. And he states that he definitely talks to his patients about that, how important that is. This is one: oral health. Large adenoids and other oral malformations could lead to what we call obstructive sleep apnea and also hypertension. I know that also falls in a pulmonary sort of category, but do you see that, or do you find? I know with obesity and that 40 40 BMI is another correlation with that, Dr. Montgomery. But do you assess for obstructive sleep apnea in the cardiac evaluation?
Yes, we do. It's actually part of the evaluation we do, especially for our patients that do have heart failure. And in this case, when we talked about the structure of the heart specifically, in a lot of cases, heart failure of the right side of the heart for sure can be a direct result of having sleep apnea or long-standing untreated sleep apnea. And, standard questions for that would be, do you snore? And if so, have you ever been told that you snore? And even if there is even a remote history of having had some history of snoring, or the patient's partner or family member says that they are snoring, we send for, I typically like to send for a sleep study right away for further evaluation, because that is a way to actually treat heart failure via something else that isn't traditionally thought of as a risk factors for heart disease. So it's very, very important, and we like to do that.
Yeah. Go ahead,
Obstructive
Dr.
sleep apnea,
Napoli.
I was just going to add a little bit. Obstructive sleep apnea, yes, has been related to the presence of heart disease and worsening heart disease. But also remember arrhythmias or irregular heartbeats. That we've also associated obstructive sleep apnea with irregular heartbeats, and two irregular heartbeats that come to mind are atrial fibrillation, that's a sustained irregularity of the small chambers of the heart, and ventricular premature contractions. Again, to explain what that means, those are irregular premature beats that occur from the lower, bigger chambers of the heart. These may occur in relationship to sleep apnea.
Right. And sleep apnea also, there's a diagnosis that we look for, is called pulmonary hypertension.
Mm.
And pulmonary hypertension is significant as far as the lungs are concerned. It causes decreased oxygen to the bloodstream, and very significant shortness of breath. And basically, what happens is that the blood pressure in the lung vessels, which is separate from those vessels throughout the rest of our bodies, the lung vessels become the blood pressure in those vessels increase. And if that occurs, then when the blood comes up from the right side of the heart through the veins and goes through the right side of the heart, when it's expected to go through the lungs, what happens that there's a back pressure because of that high blood pressure in the lung system, and that blood can't go through easily, and you become very, very short of breath. So that's pulmonary hypertension, and that's can be secondary to obstructive sleep apnea and that particular disease. Patrick, you have your hand up?
Yeah, I just want to ask, when we talk about atrial fibrillation, does it does it matter which atrium is affected to have the risk of things like stroke, whether it's on the right side influenced or left-sided influence?
Well, in atrial fibrillation, both atrium may fibrillate. There may be similar electrical abnormality which can affect both. But in terms of the strokes, remember that for the usually our concern with atrial fibrillation, or one of the major two concerns, is the presence of clot formation within the atria that are fibrillating. In other words, when the atria are fibrillating, that is, they're not beating adequately or synchronized manner, like a bag of worms, just that kind of movement of the atrium. Blood stagnates to some extent, and in a certain portion of the atrium, and here I'm talking more specifically of the left and the right, in that area, clots may form. Now, what's the danger of the clots? The danger is not in being there, but the danger is in moving from that location to a further location. Now, on the right side, the location they could move to would be, of course, to be the lungs, and that's not as common or as significant a problem as the one on the left. On the left side, the clot that leaves the left atrium, we talk about the atria, the left one, and goes into the bloodstream on the left side, has a major danger area of target. That is the brain. Mm-hmm. So if that clot goes to the brain, then it could cause a stroke. But that's more likely to the left side, unless you have unusual circumstance of paradox on the right, and other circumstances which are a lot rarer, but more important in terms of common circumstances. Atria, fibrillation of the atria, affecting clot formation on the left predominantly and going to the brain. Those are the big dangers. These are the big red flags that we worry about.
You're ready. Thanks for Dr. Atherley. There was one question that came up, and I think it was talking about the supplements and things like that. It states, I take cod liver oil, still good. So guess what? All my life coming up as a child and into my younger years, I was forced to take cod liver oil, and I'm still here. So I guess it is still good. I'm sure some of us have had the same experience.
Yeah, I guess our parents and foreparents are a little bit wiser than we give them credit for, because that cod liver oil is rich in the fat soluble vitamins, the A, the E, the D, and the K, so to speak, which are often not readily available in a lot of the foods we eat. The good thing about fat soluble vitamins is your body can store them. So if you take your consistent dose of cod liver oil, then you'll store some of those vital vitamins and that you may not get in your diet. So our parents were more intuitive than we give them credit for.
Yeah. And also, that oil allows for easier bowel movements as well. And that's important.
Right.
In the sickest patients in the hospital, we monitor daily bowel movements. It's important to have those bowel movements because toxins build up in our gastric system. And, you don't realize how important, just a good bowel movement is to get rid of certain toxins. And yeah, cod liver oil helps in that direction as well. All righty. Let's go with the next one here. It states, I was given Astrovastin for high cholesterol, but read that statins can affect the kidneys. What other alternatives along with change of diet is safe? Okay, so we're talking about all right, statins, and there's a lot out on statins and CoQ10 and all of that. Can you give us some understanding, either Dr. Atherley or Dr. Montgomery, about statins and the safe and the effectiveness as far as that's concerned? Either way.
Yes. So statins are, I think statins are great medicine. I think that there's a lot of studies behind them that show that specifically not just in controlling, high cholesterol or in patients that have history of high cholesterol, hyperlipidemia, but also for decreasing inflammatory effects. And so oftentimes after patients do have either a heart attack or a stroke, the recommendation is that they be placed on a statin to kind of help decrease some of these inflammatory states, to which ultimately can go on to progress to further cardiovascular or neurovascular issues. I think that there has been a lot of information, if you will, on statins. If you research statins out there, as far as different side effects, and some of which have definitely been panned out in research studies and things like that, such as in certain patients can get severe muscle pain or etc. In their legs, which is, in my experience, been a minority of patients, but it is definitely something that can happen and that you have to be on the lookout for. There have been other reports, I'm not sure to what extent, about there being elements of brain fog, if you will, or issues of mental mental decline. I think these are definitely sentiments that are out there. I'm not sure to what degree that they have prevalence in the general population, but it definitely is something that's out there, and something that if you know look at statin boards or anything on the internet, there's all kind of side effects and things like that that are explained with statins. So I think really it's about really weighing the risk and benefits of any medicine, if you will. And I think in large situations that where you do have clear indications to be on them, my recommendation, at least, you should try it and see how you tolerate the medication, and if so, then the benefits would outweigh the risk.
Yeah, Omar, I know we're running short on time, but I really want to ask this question to both Dr. Montgomery and Dr. Atherley, and it may be a segue into a possible topic for one of our meetings in our lounge, maybe after a few drinks. But a colleague recently had an MI, a heart attack, so to speak, and he's talking about modifying diets and medication that he's on. And I asked him about, was there a conversation about cardiac rehab? And it's an approach to cardiac care that I don't have a full understanding of it. Could you guys talk a little bit about that? After what do you do for patients from a fitness perspective? Someone who's recently had a heart attack or had like bypass surgery, those kind of things.
Yeah. So, cardiac rehab from the heart. So, specifically regarding for after a heart attack, it's actually now a high recommendation for everyone that does come in that does have a heart attack, that when they go home, they're discharged with a prescription to undergo cardiac rehab. And the best way to describe cardiac rehab is what I say is sort of like a supervised exercise program, where you are able to go and do the kind of cardiovascular aerobic exercises that you would do, say, at the gym, whether or not it's the treadmill or it's the elliptical or it's the stairmaster. Do those, but under the care and under the supervision of an exercise physiologist who is there to monitor your vital signs, there to monitor your heart rate, your blood pressure, all of these other aspects of health, to make sure that number one, you're progressing appropriately, that in spite of being on new medicines, that your body is having appropriate responses to exercise, but also to make sure that you're not overdoing it, and that you're not and that you're progressing as nicely as you can. Because having a heart attack and having heart failure, and I send my heart failure patients for cardiac rehab all the time, it can be just as much of a physical sort of issue as it can the mental issue. And your body is not necessary. Your body is there's a delta between what you feel like you can accomplish mentally versus what your body is telling you that you can accomplish at times.
Mm-hmm.
And so cardiac rehab in that state is a way to kind of have you go back so you can learn to trust your body again, and learn to be able to do a lot of the things that you used to be able to do, and just to kind of get back to sort of your baseline functional status. And we have a great, plug. We have a great cardiac rehab department at the Beth Israel that I utilize all the time, and the guys and girls on there are great. And so we've had a lot of success with them, and I send my patients to it all the time.
Excellent.
If we assume and we have documentation of not cardiac rehabilitation primarily, but exercise being of value in promoting the process of the heart function after heart attacks, after heart surgery, and with congestive heart failure, that this is just a means of ensuring that it's done in a properly synchronized and supervised way, so that we again get back to improving the function of the heart after it has suffered these onslaughts of, as we mentioned, the terrible ones of heart attacks and etc. That this helps us in receiving synchronization of the methodology that is used, and the supervision is required only for a brief period of time. We go through several stages of cardiac rehab, first stage, second, etc. And after a while, it is merely showing the patient how to do exercise on their own without the need for supervision in the rehab area, but implying the continued use of exercise as a lifelong method of helping their hearts.
It's interesting to me that you use exercise for cardiac recovery, but also use it in a diagnostic way, right? Because that's what essentially the basis of your stress test, right? Your physical stress test, yeah.
That's
Indeed.
And nutrition is actually a big part of that as
Oh yeah.
well. So yeah, don't forget the nutrition, boy. I'm big on the N. Nutrition, nutrition. All righty. So this was great. Dr. Montgomery, thank you, thank you, thank you. You slammed it
No,
today, brother.
thank you all for having me. Definitely, this was definitely a treat and I'm just glad I was able to add to the conversation. So this is great. Thank you again.
Yeah,
All
and I
right.
gotta tell you, I see Dr. Atherley and Dr. Montgomery all the time,
Yeah.
and it's good to know that I have this level of talent to help me out. Because, like I often say to folks, and Dr. Atherley laugh at me all the time. I break hearts, I don't fix them. So I'm glad to have you guys around to not make me look so bad.
Definitely. Well, Dr. Montgomery, is there anything you want to end with? The one thing, just anything you want to end with, just a highlight or like note these symptoms or anything you want to end with before the show is over?
So really just specifically pertaining to heart failure, which we were started talking about, I think the main thing with heart failure is to really pay attention to first know your numbers and know if you do have any any syndromes or any clinical conditions which would make you at higher risk for having any type of heart disease, whether or not that's what we spoke about before, high blood pressure, high cholesterol, genetic, disposition, etc. And then also really paying attention to your body and really knowing, if you're having symptoms. And I think all of us are, at least at some point, um, guilty of this, of where we may have a couple of days where we don't feel too well and we feel like we're, either under the weather or we attribute it to something else of that it could be. But really, it could be signs of heart disease or even heart failure. And so these are something that, definitely if these things are occurring, you should go to your physician as soon as possible to explain these things and really find out if further investigation or diagnosis or treatment is warranted. Um, and then just lastly, heart failure, I think, should go through a new branding campaign because it sounds extremely morbid with heart failure. But I think now with the advent of a lot of therapies and from medicines to really, exercise and really knowing, about functional status and everything else, as well as even having for severe end-stage heart failure, the options of heart transplant or even LVAD, there's a lot of therapies that are available for patients to be able to be treated. So if you hear heart failure, it is not in today's day and age necessarily a death sentence. It is something that is very treatable and diagnosed early and treated properly is something that we can definitely be in partner with to treat and keep you stable for a very long period of time.
Excellent, excellent. Now on that note, we're going to end the webinar. It was excellent. I'm so glad we were able to cover this topic because we don't get a chance to actually talk about this topic. It's important, especially important for our culture because we just don't get this information about how to support the heart transplants, and what we need to do. Because without the ticker, as I started, we're not here without the ticker, so we got to keep it healthy. All righty, so let me just end with closing remarks. Thank you, OBHealthy, for allowing us to bring this webinar to you. Please check out their platform. Um, every second Saturday at 1 o'clock, we are trying to be here. We will be here. Well, in case a couple times we're not here, but if we can be here, we will be here. All righty. And it's at 1 o'clock. Just go to OB Healthy, click on that doctor's tab, come on in, ask your medical questions. We will try to answer them. Number one, and we'll try to have interesting topics for you, like the heart failure today. Remember, caring and sharing. It's all about letting other people know about us. It's about, healthy Black communities as far as health is concerned. And we got to get the word out there that we're here, we're talking health, and have people chime in. The most important thing that I can say is please do not change any aspect of your medical care until you consult your physician. I don't care what we say, only your doctor, your personal doctor, can truly take care of you from a medical standpoint. And if you've missed any of our webinars, please go to the website and hit the YouTube channel and just check them out. It's all there for us. Until next month, I'm going to say peace to everyone and thank you, each and every one of you brothers, for coming on And Dr. Montgomery, again, you slammed it. Thank you very much. We're going to look forward to having you back again, or even if we can get you part of the panel, we'd love to have you because the wealth of information wealth of knowledge that you give is so important. All righty. Peace, everyone. Have a good month, and we'll see you next week, next month. Yeah, definitely. All right. Peace.